Hello, my name is Kate Chesterman. I'm a salaried GP in South Norfolk, and I also co-host the GPnotebook study groups. Welcome to the GPnotebook podcast, where we discuss bite-sized topics aimed at all those working in primary care. You can find us on all major podcast platforms, including Spotify and Apple Podcasts. Please follow us to receive notifications about new episodes, and if you like what you hear, please consider leaving a review to help other listeners find us. You can also follow us on Twitter at GPnotebook for more information about new podcast episodes and study groups. Finally, you can visit GPnotebook.com for podcast episode show notes and to find out more about upcoming study group meetings. Today, I'm going to be talking about paronychia. We're going to be thinking about the differences between acute and chronic paronychia and considering the causes, treatment, self-management and prevention. So I hope that you will find this a useful update and that I can give you a few tips to think about when managing this common condition. So paronychia is an infection of the proximal and lateral nail fold and can affect the hands and feet. It occurs when there is disruption to the epidermis or cuticle, which should form a protective barrier between the nail and the nail fold. This disruption allows bacteria to be introduced to the area and predisposes to infection. Paronychia can be classified into acute and chronic. In acute paronychia, the condition has been present for less than 6 weeks, and usually only one digit is affected. The symptoms are typically of quick onset, and the affected nail fold rapidly becomes hot, swollen, red, and tender. There may be a fluctuant collection of pus present, and in severe cases, an abscess can develop. If you are unsure whether an abscess is present, you can apply the digital pressure test. To perform this, you should apply pressure over the volar aspect of the affected digit, and if a larger than expected area of blanching is visible, then an abscess is likely. Rarely, the infection can spread under the nail plate and result in a subungual abscess. A fever is rare, and if present, you would need to consider whether there has been spread of the infection to surrounding structures, resulting in an osteomyelitis or infected tenosynovitis. Such cases are thankfully rare and are more common in those who are immunosuppressed or who have left their paronychia untreated. Acute paronychia can occur spontaneously, but is also frequently the result of trauma from nail biting, picking at the skin around the nails, splinters, and aggressive manicuring. Damaged or diseased nails or nail folds due to underlying skin conditions such as eczema, psoriasis, or contact dermatitis, or damage from ingrowing nails also increase the possibility of infection. Acute paronychia is more common in children and young people, probably due to associations with trauma and thumb and finger sucking. Acute paronychia is commonly caused by a staphylococcal infection, as damage to the epidermis or cuticle has allowed this normal skin flora to invade the area. But it can also be secondary to streptococcal or Pseudomonas infections, or more complex aerobic and anaerobic infections if the area is in contact with oral flora because of finger or thumb sucking in children. Herpes simplex infections can also occur. These are usually associated with lancinating pain and the presence of painful vesicles, and, if present, needs prompt treatment with antivirals. So, how do we manage acute paronychia? Well, warm soaks for 10 to 15 minutes 3 to 4 times a day have been shown to be beneficial in alleviating the pain associated with the condition, as well as localising the infection and encouraging the drainage of pus. Patients should be encouraged to keep the digit clean and dry and to avoid further trauma, and emollients should be used regularly. Simple analgesia with paracetamol and non-steroidal anti-inflammatories can help manage pain, and for mild cases, this and the soaks may be sufficient treatment. Minor localised infections can be managed with additional topical antibiotics, such as fusidic acid, and you should consider oral antibiotics for more severe infections or for those at higher risk of complications. These antibiotics need to be effective against staph infections, so flucloxacillin or clarithromycin are usually given first line. Acyclovir should be prescribed if herpes simplex is suspected or confirmed. Swabs can be considered if the infection is not settling or if there is doubt about the diagnosis, and these can be tested for bacterial, viral and fungal infections if indicated. If a fluctuant pus collection or abscess is present, then the patient may need an incision and drainage, and this will often require a referral to the emergency department or surgical team. Follow-up is not usually required in the treatment of acute paronychia if surgery was not required, but patients should be advised to seek medical attention if their symptoms are not improving or getting worse. Chronic paronychia is a paronychia that has been present for more than 6 weeks. This usually results from an inflammatory dermatosis of the nail folds that causes a retraction of the periungual tissues. It often starts in one nail fold and progresses to other digits. Each affected nail fold is swollen and lifted off the nail plate, and this allows the entry of organisms and irritants. Over time, the nail plate thickens, discolours and distorts, and this can result in transverse ridges forming in the nail, which can be permanent if the nail bed is damaged. Chronic paronychia is usually less painful than acute paronychia, but it can be tender from time to time. The areas affected are often red and swollen, and the nail fold can feel boggy, but areas of fluctuance are rare. Chronic paronychia is predominantly a disease of domestic and catering workers, bar staff, beauticians and fishmongers, whose occupations result in prolonged exposure to water and chemicals that eventually cause a contact irritant dermatitis. It also occurs in those with eczema and psoriasis, and in children who suck their thumbs or fingers. It can be more common in those who have poor circulation or diabetes. Women are more frequently affected, most often due to irritants they may be exposed to. And finally, some medications can also cause chronic paronychia, including retinoids and antiretrovirals. The wearing of gloves or artificial nails creates a warm, airless environment that predisposes those with chronic paronychia to fungal and yeast infections, particularly Candida. And streptococcal and Pseudomonas infections are also more common in chronic paronychia. Again, the diagnosis is usually a clinical one, but you may want to consider checking for diabetes, swabbing the area if infection is suspected, or sending nail clippings if there could be a fungal infection of the nail. If you suspect an irritant or allergic dermatitis, then a referral to dermatology for patch testing may be indicated. So the management of chronic paronychia does differ from that of acute paronychia. Firstly, it is important to manage predisposing factors. It's still important, as we saw with acute paronychia, to keep the hands warm and dry, encourage regular emollients and avoid further injury. But in addition, it's imperative to avoid further irritants such as soaps or detergents, pressure and occlusive factors such as false nails. Chronic paronychia can be difficult to cure, but avoidance of irritants and management of any underlying skin condition may help lead to a gradual resolution, although progress can be slow. Topical treatments may need to be considered. Steroid creams such as hydrocortisone or betamethasone may be required for up to 2 to 4 weeks. And antifungal creams such as clotrimazole, miconazole or terbinafine might be needed to manage fungal infections. Antifungal creams and steroids can be prescribed in combination if indicated. Lotions or drops may give better penetration, and consideration can be given to prescribing products such as clotrimazole solution. Trimovate can be useful during a flare-up as it provides steroidal, antiseptic and antifungal properties. Occasionally, systemic treatment is needed in the form of antifungal tablets such as terbinafine or itraconazole for troublesome fungal infections. But thankfully, surgical management with an incision and drainage is rarely required for chronic paronychia. If there is an underlying skin condition, then this needs to be treated appropriately, and the management of any diabetes and circulatory issues can also improve chronic paronychia. If the condition is felt to be iatrogenic, then a change in medication could be considered in consultation with the patient's specialist team. In terms of prevention of paronychia and avoidance of recurrence, we can advise that toenails should be cut straight across and ingrowing nails need to be avoided. Nails should not be trimmed too short. Patients should be advised to avoid nail biting or finger sucking and to dry their hands thoroughly after washing. Gloves and artificial nails should be avoided for prolonged periods, and if it is necessary to work in water, then cotton-lined rubber gloves should be worn. Finally, I would recommend giving patients a copy of the excellent British Association of Dermatologists leaflet, How to Care for Your Hands, and I've put a link to this in the show notes for this podcast. So, thank you all for listening. I hope you found this podcast helpful. Please do have a look at the show notes that accompany this episode at GPnotebook.com. I would be very grateful if you would consider following the podcast and leaving us a review on your favourite podcast platform. Feel free to get in touch via social media at GPnotebook or email support@gpnotebook.com if you have any questions, comments or ideas for future episodes. You should also visit us at GPnotebook.com to register for our virtual GP Notebook study groups and download free shortcuts which are designed to help make your lives a little easier and ultimately help improve the lives of our patients in primary care.